All of you to the 29th live webinar on orthopedic principles. This time we have Professor Venu Kavarthapu, who is a consultant orthopedic surgeon at King's College London, United Kingdom. He's also associated to the University of Southern Denmark and also a senior lecturer at King's College London University. Currently, he serves as the head of King's Young Adult Hip Services, which is a regional service for hip arthroscopy and arthroplasty. He also serves on the education committee of BOFAS. He has been the past president of the Indian Orthopaedic Society UK, a very vibrant organization, and is currently the president-elect of Association of Diabetic Foot Surgeons. Today, he's going to enlighten us on the role of femoro-acetabular impingement in hip pathology, and it's going to be tailored to the fellowship exams. Over to you, Prof. Venu. You can share screen.
Thank you very much, Dr. Gopal, and thank you for the introduction. And I'm really impressed with your orthopedic principles teaching work. I'm really glad to be part of this. So, greetings from London and from my institute, King's College Hospital in London. Right, you know, if you look at the hip topics covered during the FRC's ortho exam, they are quite numerous and vast. They do ask questions about basic sciences in the viva and in the clinicals as well. Osteonecrosis is still a very popular topic in the hip region. Hip dysplasias, a lot. Osteotomies around the hip as well, they are commonly asked. Hip impingement was not really covered, say, about 10, 12 years ago, but it has become quite a common topic more recently in the FRC's ortho exam. So it is critical that you understand about essential components of hip impingement treatment. A lot of questions will be asked on cemented versus cementless total hip replacement implant, and also occasionally conversion of arthrodesis to a total hip replacement, particularly in the clinical scenario. More recently, a lot of questions are asked about curves, which is getting it right first time, which is a major practice change within our arthroplasty clinical practice, not only in the arthroplasty, in other regions on the surgical side as well. National Joint Registry, ODEP ratings as well. And when it comes to the clinical components, particularly on the clinical exam side, there will be questions on the complications of arthroplasty, such as heterotopic ossification, instability, loosening, the modes of failure of hip implants, osteolysis in particular, and also the principles of revision, hip arthroplasty, covering both the aseptic and septic aspects. And you can see the topics are numerous. In order to pass the exam, you need to get an average of 6 in the clinical and viva setting. The hip topics, the standards of this knowledge and your answers are higher. So you really need to acquire all the required knowledge and skills in that area to reach 6. But if you impress upon them well on hip impingement questions as well, you might even get 7. So your aim is to get 6, but to get 7, it's good if you get asked about hip impingement, you can give them more than what they expected. Well, just before we go through the full presentation, let me introduce you to this orthopedic colleague who is currently practicing in Australia, a hand surgeon, but he was a trainee in our region in 2006, an extremely physically active gentleman, and he used to participate in marathons regularly. He presented with left hip pain, and that had been going on for a while, and he was seen by his then boss, a lower limb surgeon. So he presented with bilateral hip pain, but a lot worse on the left side. And that was related to his endurance physical activities. The routine hip examination performed at that time was labeled as normal. And the x-rays were also labeled as normal at that time. Means there were no degenerative changes. There was no traumatic changes, fragments or bone fragments noted. And he had a course of, or multiple courses of physiotherapy with no significant benefit. So the management plan at that time was either to keep following up, or he should give up his endurance physical activities, which he loved the most, the marathon running and other triathlete related activities. So let's brush up this topic of hip pain in young adults, and you can label them as extra-articular and intra-articular. And the extra-articular sources can be from the tendons and other structures around the hip region. The intra-articular, again, at that time, avascular necrosis was still very common, synovial chondromatosis, dysplasia. But there was this newer concept at that time coming into our clinical picture, the labral pathology, chondral damage, and this new phenomenon called hip impingement. Well, if you look at, I've been delivering this service for Southeast London region since 2006, and my hip fellow in 2013 did a simple cross-sectional audit on my hip clinic practice at that time. This was in 2013, and out of 150 patients in the young adult group at that time, between 18 to 40, which we labeled as for this particular service. During that time, out of 151 patients, a certain number, 12 presented with dysplasia, hip dysplasia as the diagnosis, some avascular necrosis. But look at this. Even at that time, a number of patients were diagnosed with hip impingement, and in fact, this proportion is even greater nowadays in our practice. So hip impingement, at least in the UK, is quite a common and very important clinical and diagnosis in most young adult hip patients. So what is this hip impingement? Well, it was not until Professor Gans described when he identified this phenomenon in young adults presented with hip pain, and the x-rays were more or less normal at that time. And there was also an apparent relationship with early osteoarthritis, which was identified later. And this was found among these young adult patients that had undergone periacetabular osteotomy for hip dysplasia. So this hip impingement, otherwise called femoro-acetabular impingement, is characterized by an abutment between the proximal femur and the acetabular rim during the normal range of hip motion or during normal physical activities. And this repetitive conflict causes lesions of the labrum and of the acetabular articular cartilage, possibly leading to secondary osteoarthritis. And this was the understanding at that time when Professor Gans had described. And you can see the pictures on the right side. The top picture, cross-sectional picture of the hip joint, shows a normal shape. The second or middle picture shows some abnormality at the femoral head-neck junction on the femoral side, and the bottom one shows this abnormality on the acetabular side. And this particular study first showed this relationship. And it talks about cam impingement and pincer impingement. What is a cam? Cam is an engineering structure or engineering term. And you can see in this picture, you have the circular part. This is nice and circular, but this shape is called cam. And it is commonly used in certain engineering structures. So the picture on the right side, that hip is a normal hip. And you can see hemispherical femoral head with clear head-neck junction, and the neck narrows down beautifully. And that hip has a really tiny micro point of center of rotation, whereas the picture on the left side shows this cam shape. A pincer is this particular instrument which has sharp edges for particular purpose. Again, in comparison to the normal hip joint with normal acetabulum on the right side, the left picture shows this pincer morphology. whatever the morphology is, either the top one cam or the bottom one pincer, the common phenomenon here is this abatement between the femoral head side and the acetabular side. Just this, if you look at this picture, which shows a cross-sectional aspect of a normal hip joint, acetabulum with labrum, red colored at the edges, and the femoral head, perfect hemispherical with one center of rotation, and you have the head-neck junction. And that hip, if it is taken to full flexion, when the femoral head-neck junction or femoral neck touches the acetabulum during extreme range, you see that abattement. And the bottom, this picture shows a cam type shape. You can see that the center of rotation is not one pinpoint. It is not a perfect sphere or hemisphere. And as this hip flexes, the abnormal shape is already abutting the hip joint at the top here. And that causes this abutment, and this repetitive conflict is the hip impingement. But on this, in this example, it is due to the cam shape of the femoral head at the head and neck junction. If you look at this example, the acetabulum is more prominent. The acetabular rim is more prominent superiorly. And even with a normal femoral head neck junction with perfect hemispherical femoral head, during normal physiological range of motion, there is an abutment between the acetabular rim and the head and head neck junction. And these are examples of cam and pincer hip impingement, causing, on this occasion, the pincer one causing the abutment and impingement. So this orthopedic friend, who is now very busy doing carpal tunnels and even finger reimplantations, clearly has got a cam impingement. But at that time, in 2005 and 6, the knowledge on this condition was not widespread. And even the radiologists had initially diagnosed this as normal, but it is now very clear. And in fact, all radiologists and orthopedic surgeons can now easily identify this pathology. So one important feature you need to remember is that in the lateral view, you can see that bone prominence. So it's present in the AP view on the lateral side. In the lateral view, this cross-table lateral, you can see this bone prominence anteriorly. So this cam shape, that bone prominence, is present in the anterosuperior or anterolateral aspect of the femoral head neck junction. So that needs to be very clear. So these patients present with hip pain, usually related to certain type of high impact or endurance physical activities that involve hip flexion with or without rotation movements, the internal rotation in particular. But as the pathology progresses, even routine hip flexion rotation movements, such as getting in and out of car, or getting up from a low settee or chair, can be painful. And when the pathology advances, it leads to constant pain, even at rest. Usually by that time, the patient will have developed secondary degenerative changes. So the hip examination is not much different to a routine hip examination most of you are familiar with. In the exams, it is good to do the hip examination while standing, which includes the gait, and a brief examination while sitting, which includes a quick screening examination of the spine and the knee. You don't spend too much time on that, but very quick screening examination. And then rest of the examination while lying down. And we're not going to go through the full standard hip examination here, but that lying down examination should include the hip impingement sign or hip impingement test. Here, we are talking about young adults, otherwise look fit and healthy, but they have groin or hip region pain. The hip is taken into flexion and adduction plus internal rotation. And what you're doing here is forcing the hip femoral head neck junction into contact with the acetabulum. And if there is hip impingement, that rotation movements are markedly reduced and the patient experiences, this reproduces the patient's pain. So there is a limitation of hip interrotation flexion, quite significant compared to the opposite side, if the opposite side is normal, or compared to what is normally expected, and also the pain is reproduced. So then you do further investigations. Plain hip radiographs are extremely helpful. In this case example, this patient is again very, very young. He's in his early 30s, and you can see already the plain pelvic radiograph, a well-done radiograph, shows bilateral cam impingement lesions with early degenerative changes already. There is subcorneal sclerosis, loss of reduced joint space, and even cyst formation. And this is the lateral view, quite a large. But interestingly, this patient still chose to have hip arthroscopy done, and it is now about 4 years, and he is still doing fairly well. He's unable to do endurance activities, but he is still able to do most of his sporting activities quite well. Whereas for pincer lesion, pincer pathology, the imaging concept is quite different. You need to do a well-centered AP pelvis and also a cross-table lateral. So here, we are essentially looking at the center edge angle. You all know what a center edge angle is, and if it is less than 20, it is dysplasia. 25 to 35 is normal. If it's more than 35, it is pincer. And again, this pincer pathology can be very focal or global. Focal can be due to simple bone protrusion in the anterosuperior aspect of the acetabular rim, or due to excessive femoral acetabular anteversion or retroversion. Or it can be global, such as protrusio or profunda. And how do you diagnose this? Based on the cohulus line position and in relation to the acetabulum, the posterior wall sign, the crossover signs. You're all familiar with these radiological markers as part of your hip dysplasia study. So in essence, if the center edge angle is greater than normal, that is potentially a pincer impingement. A CT imaging is extremely helpful in diagnosing pincer lesion and also a large cam lesion. But the workhorse investigation is MRI imaging. So the CT helps you identify the axis of the femoral neck and the femoral head neck junction. And based on that, there are a number of formulas. You really don't need to know in detail about these formulas for your FRC soft exam at all. But I just want you to make yourself familiar with this phenomenon. If the femoral neck is very wide, that also affects the alpha angle, which is drawn from the center of the hip rotation, that point at the axis of the neck, to the junction between the sphericity of the femoral head with its junction with the neck. So that angle should be less than 55. And you can imagine if the greater it is, the greater the possibility of a cam lesion. But the point I'm making here is that if the femoral neck is wider, that will also have a negative effect on the alpha angle, means the hip impingement risk is also very high. But you don't need to know in detail about these figures, angles, and the formulas, but I would like you to be aware of this. And similarly, if the femoral head is in retroversion in relation to the neck, then that also increases the alpha angle. So alpha angle, if it is greater than 55 on Dunn's view, or 42 degrees on frog-leg lateral view, it is significant. And this lateral center edge angle, which is on the AP view, a very well centered AP pelvis radiograph. If it is greater than 40 degrees, that is significant, and that is pincer. In the presence of significant clinical findings and MRI imaging findings. So MRI imaging is extremely helpful to assess the femoral and acetabular bone geography, and also the hyaline cartilage, acetabular rim, and the periarticular ligamentous and other structures. MR arthrogram is even better because the pathologies appear even more clearer. This is entirely related to the surgeons or radiologists' preference, but in our institute, we prefer to do MR arthrogram. And I know that in some institutes, plain MRI is preferred. So MR arthrogram can outline the femoral head neck junction beautifully. It also shows the labral tears quite well. And you can also do 3D reformatting, and I will show those pictures earlier. And at that time in 2012, these were the sensitivities and specificities for labral tears and condyle damage, but now they're even better. And you can also do 3D reformatting using MR arthrogram or very high-powered MRI, and that allows you to map the femoral head neck junction and cam lesion, and that can help you plan your surgical procedure as well. Modern imaging tools are also helpful, the degenerate MRI, 3D MRI, etc. So the management, once you make the diagnosis, is still operative versus non-operative. Personalized hip therapy is still there, it has got a significant role. And in fact, a very useful high-powered study was published looking at the hip arthroscopy in comparison to the best conservative care, which is the personalized hip therapy in the management of femoro-acetabular hip impingement. The UK fashion study, a multi-center randomized controlled trial, and my unit was also part of it, and that has shown for a change that the hip arthroscopy is superior compared to physiotherapy in this group of patients. And you can, I'm pretty sure that you understand that certain other conditions or certain other orthopedic procedures, such as the knee washout for arthritis or shoulder subacromial decompression, had different outcomes in these studies, but the hip arthroscopy is found to be the appropriate treatment for hip impingement. So what is the objective of surgical treatment in this group of patients? We're talking about surgical treatment. The aim is to address this problem because there is a growing body of evidence that supports the theory that idiopathic hip osteoarthritis is actually caused by femoro-acetabular impingement in most patients. So the aim is not to just address the hip symptoms of these patients, but also perhaps protect or reduce the risk of the patient developing hip osteoarthritis. So during the surgical treatment, we do the osteochondroplasty of the femoral head, means we correct the shape of the femoral head neck junction to normal by removing the cam lesion. If there is pincer lesion, we do rim excision and recess the acetabular rim. If there is labral tear or detachment, we debride the tear and reattach the labrum. If there is condyle damage or condyle delamination, do chondroplasty and microfracture or other urgent condyle procedures. Or if there's ligamentum teres pathology that can be addressed, or if loose bodies that can be addressed, and so on. So that can be achieved through an open or arthroscopic technique. And indeed, until about 15 years ago, most of these higher, complex therapeutic procedures were done through open approach. And in some centers, they still do open approach. And in my practice, open approach was used 50% of the times at the beginning in 2006 but now it is rarely used. This is done through a surgical dislocation approach, Gans osteotomy, and this allows complete circumferential correction of head neck abnormality, and then you fix the trochanteric osteotomy back, and you achieve beautiful correction. For large pincer lesions, similar technique is done, and you can reattach the labrum or reconstruct the labrum or using open technique. But hip arthroscopy is the most commonly performed procedure for most of these pathologies, except severe, very severe deformities. So hip arthroscopy, there is massive literature available, but you can have a look at this article as well, published a couple of years ago in the Indian Journal of Arthroplasty. So hip arthroscopy is done using supine or lateral position. I do lateral position, but the common principles in both these positions is hip distraction technique. You have to distract the hip joint to be able to safely pass the camera and instruments into the hip joint without causing any damage. And this portal placements is done under fluoroscopy. And naturally, we use cannulated introducers, pass the wire in first, and then the introducers and instruments passed over the wire through the cannulated setup. And because the hip joint is deep, the instruments are all long handled, unlike the ones used for the shoulder or the knee. 70-degree long scope is the workhorse arthroscopy device, but 30-degree is also used. So when we do the procedure, we divide that procedure into two parts. The central compartment, all of that hip joint present within the labral rim is a central compartment. And the peripheral compartment outside the labrum, but within the capsule of the hip joint. And you can imagine this, to access a central compartment, you have to distract the hip joint. But to access a peripheral compartment, you don't need to, so you can reduce the hip joint and access the peripheral compartment by maneuvering the hip into flexion, adduction, or rotation movements. So this is the hip distracted device, and it is done using the image intensifier position like this. But the image intensifier can be positioned the other way, it's surgeon's preference. And it is critical that you set up everything before you start the hip distraction and then confirm that you achieve adequate distraction before you actually start draping the patient. And you can see in the eye picture there that there is a good distraction. Once you achieve good distraction to whatever point it is, you just mark that point and release the traction, because you want to reduce the traction time to the minimum. The longer the traction time, the greater the risk of some complications, particularly the nerve traction injuries. So you first distract the hip joint, check under the image intensifier. Once you're happy with the amount of distraction, you mark that point and release the traction completely. And then drape the patient and prepare the instruments and everything. And just before you start the procedure and pass the needle in, you distract the hip joint to that point again. And then what do we do? We pass the needle into the portal and the wire through the needle, and then the camera over that wire once you dilate your portal serially using whichever size sheath you use. And you do the second portal. There are a number of portals used, and again, unlike the shoulder knee arthroscopy, which has beautifully standardized techniques, the hip arthroscopy, perhaps because it was developed by multiple experts around the same time, more variations, but equally equally powerful techniques were developed. So hence, there are quite a few portals: the supratrochanteric portal, superior portal, anterolateral portal, anterior portal, anterosuperior, posterior portals. So I think it depends on the surgeon's preference, and we generally you do 2 favorite portals and reserve the 3rd portal for peripheral compartment. But whatever the portal, the camera portal, if it perforates the capsule superiorly, that's around 12 o'clock, and if the anterior or anterolateral portal it perforates the capsule between 2 to 3 o'clock, then if you join, if you do a capsulotomy to join these portals, that will give you a wide range of flexibility to maneuver your instruments and cameras. So if you look at this example picture, so the camera is inside the hip joint through this portal, and if there is no capsulotomy, that is the area of visibility you will have with that 70-degree scope. But if you do a nice capsulotomy, you can maneuver the camera around and reach most of the areas of the hip joint. I will just run through briefly the technical aspect. Again, you don't need to know in detail about the surgical technique, but it's good to have an idea so that you can speak confidently in the viva. So in this picture, the camera portal has been established. The camera is inside the distracted hip joint in the central compartment, and you have established a 2nd portal, and just passing the radio frequency probe through the 2nd portal. And you can see synovitis there. The labrum is here. This is the hyaline cartilage of the acetabulum. This is the femoral head. The hyaline cartilage of the femoral head is well preserved. The labrum looks fine. There is some erythema there because of the ongoing impingement process. And you can see the labrum is a bit more freely mobile. Normally, it is a lot more firm. But here, what I'm doing here is I'm opening up the capsular opening. The capsule is very thick from there to there. You need to open up the full thickness of the capsule. And I'm coming towards the camera portal, and my aim is to join these 2 portals so that you can play with it better. Then you pass the probe, and you just probe most anatomical areas. Here, this is the anterior part where the 2nd portal has come through. This is the labrum, and clearly there is chondrolabral damage, tear with some hyaline cartilage delamination here, and that is due to ongoing impingement process here. As I rotate the camera, we're looking at the superior part of the acetabulum, and if you keep rotating the camera, you can look at the posterior part. And this video shows a large acetabular hyaline cartilage delamination. It feels and looks very leathery because it's chronic and long-standing, and that is more or less dead hyaline cartilage that needs to be excised, curated out, and then you can do microfracture and everything. So if there is a labral detachment, then you can prepare the acetabular rim to reattach the labrum, and the acetabular rim preparation has already been done here. You can pass the suture anchor suture with this particular instrument, which makes it slightly more easier and quicker to pass the anchor and grab it from the other side relatively quickly. Then you drill a hole for the suture anchor, which has the suture that is passed through around the labrum, and that allows you to fix the acetabulum back to the labrum using as many suture anchors as you need. So then, coming to the peripheral compartment, for the peripheral compartment, then you flex the hip and adduct. So the whole central compartment part is best finished within 45 minutes if possible, but sometimes it takes longer. Then this is a normal looking peripheral compartment. This is the acetabular labrum. This is the capsulolabral reflection, and this is the femoral head, reduced and beautiful hyaline or fibrocartilage over the femoral head neck junction. But would like to see some concave surface here, but it still looks convex. Here, clearly, that is a cam lesion. Even with hip reduced, there is still large convex surface. And we do dynamic assessment throughout and map the size of the cam lesion and excise all of it. The aim is to get a normal head neck junction following your peripheral compartment cam excision. So in the top left video, you can see the dynamic assessment. This is the cam lesion. You can see the convex projection here. That is normal femoral neck junction. You take the hip through flexion and rotation and map the area of the cam lesion. And using a burr here, I used a 5.5 millimeter burr. If you know the diameter of the burr, you can use that as a guide to measure the amount of resection you do. It has to be far anterior, anteroposterior, and again, medial lateral as much as needed. You need to keep repeating the dynamic assessment so that you don't leave any residual cam lesion. And do the end dynamic assessment again, just to make sure that the labrum, it shows clear shelf effect where during hip flexion rotation, the labrum hangs off the femoral neck. In some patients, even in the presence of early to moderate degenerative changes, cam resection and debridement and labral reattachment can provide fantastic symptomatic improvement and can buy a significant period of symptom or free or reduced symptom period, so that the patient's requirement for hip replacement can be delayed by a considerable period of time. In this example, pincer lesion with cam component as well, combined cam and pincer pathology is a lot more common than we think. And again, after pincer excision, you can do adequate cam excision. Repeated dynamic assessment is really clear that you clear the head neck junction by as much as needed. And with repeat dynamic assessment, you can achieve full clearance. Now, based on the amount of bone and soft tissue procedure you do, I tend to limit patients' full weight bearing for a period of time between 2 to 6 weeks. If a patient requires quite a large labral reattachment with a large area of microfracture, then I tend to reduce full weight bearing activities for up to 6 weeks, but that is much less common in our practice. Most patients can return to full weight bearing after 2 weeks of partial weight bearing. But soon after the procedure, they commence hip range of motion exercises, and the physiotherapy is commenced between 2 to 6 weeks. Most patients can commence light jogging at 6-week mark and running at 12-week mark and commence endurance physical activities. There are so many studies present, but if you look at the older study results from McCarthy group, 50% pain improvement at 3 months' time, and 75% at 5 months, and 95% at 1 year. So this is kind of the experience for most of us. These patients take longer term to recover, but the impingement pain goes away soon after the procedure. In my personal series, those with grade 1 or 2 condyle damage on the acetabular side had 95% good to excellent results at 38-week mark. But those with grade 4, 7 of those 41 patients required a hip replacement at a mean of 3 years. So if there is grade 4 with labral detachment, quite a lot of them don't do as well. But had a fair share of complications among my patients group. One had sciatic neuropraxia, one had transient foot and perineal numbness, but 2 of them. And I was not good with my cam resection in 3 patients. That was the earlier time in 2007, and 2 of those had to have repeat procedures. No femoral neck fractures, and 9 had recurrence of pincer. And for pincer can recur in some patients, but CAM is not supposed to recur. CAM recurrence is actually due to inadequate resection. And as I mentioned, some of these patients required a hip replacement. But interestingly, if the traction time is less than 45 minutes, the nerve-related complications are very rare. There are expanding indications for hip arthroscopy, and that is becoming relatively common nowadays. Peritrochanteric hip arthroscopy has become very common now. Again, you don't need to know in detail for your exam, but you need to be aware that one can do psoas tendon release, reconstruction of an unrepairable or excised labrum using graft, whether it is hamstring graft or fascia lata, reconstruction of torn or impinging ligament teres, unexplained pain following a total hip replacement. It is quite routinely used as an adjunctive procedure following trauma in some big centers. Assessment of, again, failed hip arthroplasty, capsular shrinkage. Well, it doesn't work that well, but certainly capsular rent repair and capsular rent following previous hip arthroscopy, but some level of hip dysplasia following hip arthroscopy is seen in a very small portion of patients, and that may benefit from repair. Osteochondral grafts, Macy is becoming slightly more common recently, and also, it was attempted during periacetablar osteotomy. It hasn't picked up as well, but there is a huge potential. And arthroscopy assisted for the same reason, shelf osteotomy as well. So you can have a look at this systematic review published in 2015 for a bit more information. So just to summarize, a femoro-acetabular impingement pathology is a lot more common in our practice now. We think a high index of suspicion in young adult patients present with hip pain is really critical. I know that in some societies or in some regions, hip impingement is not that common. That could be related to the pathology that is suspected to be the underlying reason for CAM impingement. A SUFI, slipped upper femoral epiphysis. CAM impingement is possibly due to minor subclinical SUFI, resulting in bone prominence in that area in these young patients in their early teenage, but they don't develop symptoms until later during the 20s or 30s or early 40s. So in some countries, SUFI is less common. Maybe that is the reason why you don't see that many hip impingement pathologies in those groups, but I still think that a number of these pathologies are under-recognized in those societies and countries. But there is certainly a growing body of evidence that supports the theory that idiopathic hip osteoarthritis is in fact caused by femoro-acetabular impingement. Hip arthroscopy is proven to be a very safe and effective procedure in addressing the existing symptoms in those patients that fail non-operative measures. It certainly helps to improve the function, and at the same time, it is also, with the current evidence, known to delay the requirement for an arthroplasty in this group of patients. But the real long-term benefits is yet unknown. They are unknown, but it is most likely that it would reduce the progression of arthritis in this group of highly physically active people in the long term. With that, I would like to thank all of you for your attention, and I would like to thank the Ortho Principles team for their amazing work being done in educating all of us. Thank you.
Thank you, Professor, for that brilliant lecture. I mean, you had covered almost everything about FAI. We have a couple of questions that have come up. I'll just read those to you. One is there a role for a diagnostic injection prior to your surgical treatment? Because someone is concerned that even an abnormal morphology can be present in asymptomatic people. So whether that itself is a reason for the pain. So do you do a diagnostic injection prior to this surgery?
Absolutely. You're absolutely right. Diagnostic hip injection has a big role. And in fact, we run day surgery list specifically for that. Yes, basically, if you have a patient, young adult that presents with hip pain, means pain in the groin or in the C region, not, with hip pain presence, so-called hip pain actually felt in the lower back region or posterior hip region. So, and if your clinical examination, in particular hip impingement test, is clearly positive, and if your investigations show that there is a camera pincer impingement lesion with corresponding hyaline cartilage and labral pathologies, perhaps in those patients, there is no need to do a diagnostic hip injection. So there is full concurrence between the patient's symptoms, your clinical examination, and investigations. But I totally agree that there will be a subset of presentations, particularly patients that present with slightly vague symptoms, some hip pain, hip region pain, but pain felt in the sacroiliac joint region and lower back as well, along with slightly equivocal clinical signs and imaging findings. They will benefit massively from a diagnostic hip injection. So then a diagnostic hip injection, we give only local anesthetic and identify the response to it either soon after the injection while the patient is in day surgery or followed up in the outpatient. But in some small proportion of patients, we proceed with, if they respond well to the diagnostic injection, we proceed with viscosupplementation injection in the same sitting soon after. But in some patients, it is considered sometime later. It's a very good question. And yes, diagnostic injection has a big role.
Yeah, the other question is regarding how often do you require a periacetabular osteotomy? For example, there's a significant pincer, and if you find out the primary issues in acetabular retroversion that led to pincer, would you think doing a periacetabular osteotomy is the primary procedure?
Yes. If there is global pincer impingement, which means there's large profunda or protrusio, such pathologies are difficult or sometimes impossible to address adequately through hip arthroscopy. You don't have that great access to the posterior acetabular limb and also the most anterior part. In some big centers, they still do, but it takes a long time. And the morbidity can also be slightly greater. And some surgeons argue that it's best if that is done through an open surgery. As a part of, you can call it, you don't necessarily call it a periacetabular osteotomy, but it's actually an open surgical procedure. Periacetabular osteotomy is extremely valuable if there is isolated versional problem. If the actual acetabular shape is good and normal, but it is facing in the wrong direction, then periacetabular osteotomy is fantastic. And at the same time, you can also address the labral pathology at the same time. Yes, that corresponds to a very small portion of these hip impingement presentations. But again, it's a very good question, very relevant question. Yes.
The other concern is how often do you require a surgical dislocation of the hip to address a CAM?
Sure. It all depends on the surgeon's preference. And even in the UK, a couple of surgeons still do surgical dislocation for all CAM impingement pathologies. and their outcomes are fantastic. But it takes much longer time to recover for the patient. But any risk of inadequate cam resection is extremely low. So in their pair of hands, that works very well. In my practice, I used to do the Gans surgical dislocation. About 50% of my patients during 2007 and 2008. Any larger cam lesion was managed with Gans osteotomy in those days. But now I probably do, one a year for cam lesions. So it all depends on surgeon's preference. A lot of surgeons do mini open osteotomy, mini open procedure without actually doing surgical dislocation. And you can imagine if there is a localized cam lesion, even a larger one, but you can still access that through a mini open approach. So they combine hip arthroscopy for central compartment with a mini open surgery for peripheral compartment. And yes, in my practice, I have done a couple at some point, but I didn't find any additional benefit. And I reverted back to hip arthroscopy for peripheral compartment. And in most patients, the total surgical time for central and peripheral compartment together is around 55 to 60 minutes in my practice in most patients now, but it used to be even 2 hours at the beginning. So it is surgeon's preference. Yes, some centers or some surgeons do surgical dislocation for all cam impingement lesions. Some centers do a combination of arthroscopy plus mini open, whereas some centers do arthroscopy for everything. And in some centers in America, they do even for massive pincel lesions, everything, arthroscopically, and with really great results.
Yes, thank you for that explanation. The other point that I would want to discuss was, you said that in a particular group of communities, for example, the Asian descent, the Indian descent, you find less incidence of FAI. And I would like to quote a paper that was published from India, and they looked at the alpha angle and the head neck offset ratio. They found that that was significantly low in this part of the world. And that was the reason we did not get FAI, and less because we hardly see hip osteoarthritis in India.
Yes, absolutely. And, a lot of work is being done. And, compared to 5 years ago, we know a lot more about this pathology among Indian population now compared to before. And it still puzzles me. Yes, primary hip osteoarthritis incidence is very low among Indian population. It could be related to, the childhood, postures and everything. So in combination with, and, we all know that Sufi is much less common in India compared to, say, UK or other Western population. So yeah, in combination, yes, indeed, the proportion is a lot lower among Indian. And also, again, my previous hip fellow has done a study, an audit among our hip impingement patients. In my practice, 78% of my hip impingement patients do endurance sporting activities. Endurance means, marathon running, all sorts of things. And, it is a very important component of their life. They don't want to give up on that. So in certain societies, particularly, Eastern countries, even in some or most patients, such endurance activities, it may not be such a critical component in their physical life. So they might be willing to give up such extreme physical activities, and then the hip gets protected and they might not develop rapidly progressive osteoarthritis. But there is no doubt that there is genetic component, and the way the kids are brought up, possibly, and also the incidence of Sufi, and also sometimes there's no doubt that the actual pathology is more than what we think. If India has 100 fellowship-trained hip arthroscopy surgeons, we will definitely find more symptomatic pathologies.
Yeah, indeed, that's a great information that you have given. And I think in the UK, you have a non-arthroplasty hip register, right? NAHR.
Yes.
Kanuja leads that. I've seen him present in lectures.
Yes, Dr. Kanuja has done amazing work, and he's still doing so. At British Hip Society and International Hip Arthroscopy Society as well. And they've been doing amazing work. Because of their work, now we know a lot more about hip impingement and hip arthroscopy compared to before. And again, 10 years ago, I wasn't sure if what I was offering to my patients presenting with hip impingement symptoms was actually good or not, even though the early results were found to be excellent, but we weren't sure whether the medium and long-term results were going to be as good. But now we are accumulating major body of evidence to show that yes, the selection of the patients is critical, and if you select the right person for this procedure, the outcomes are fantastic.
Yes, true. Maybe those days the evidence was limited, and now you have a good sound evidence or high quality.
Absolutely right. Yes.
Okay. I think there are no more questions, Prof. Venu, and thank you for your time to help us with imparting knowledge on this very, very important subject. A lot of candidates are online. I'm sure they all have benefited from your lecture. This lecture gets archived within 3 hours, so everyone across the world is able to watch this lecture free of cost, and of course it is of high quality because you are the speaker.
Thank you.
Thank you very much, Dr. Venu, and I look forward for more from you in the future.
Brilliant. Thank you, Hitesh.
Thank you very much.
I love you.
The meeting.